Welcome to ICE Webinars, a cool place for hot topics. ICE Magazine is proud to bring our new monthly webinar series to the imaging industry. ICE is a community that directly links nearly 7,000 imaging professionals with a monthly magazine, online community, annual conference, and now a monthly webinar series. Each ICE Magazine issue contains insightful and relevant content ranging from technological advances to new tools and professional development. You can obtain a free subscription to ICE Magazine by visiting theicecommunity.com/subscribe. We are excited about today's presentation featuring Teri Bedard, Executive Director of Client and Corporate Resources at Revenue Cycle Coding Strategies. The 60-minute webinar will focus on interactions between radiologists and patients. Not each one of these qualifies as a billable evaluation and management service. However, if you are not billing for any EM services, you may be leaving money on the table. This session will help you determine whether an encounter is billable or whether it's included in other services the radiologist performed. New outpatient and office EM guidelines will be reviewed to discuss how these changes would potentially impact your reimbursement. The ICE webinar series would like to thank our sponsor, Revenue Cycle Coding Strategies. As an integrated company, Revenue Cycle Coding Strategies is a trusted partner of private practices, healthcare systems, hospitals, and other industry stakeholders, providing solutions for challenges in all aspects of the charge capture process. With decades of experience in both clinical and non-clinical arenas, their nationally recognized consulting team offers expertise in specialty coding, documentation, education and training resources, revenue cycle workflow optimization, and regulatory compliance. Today's webinar is eligible for one ARRT Category A continuing education credit by AHRA and is approved for one CRA credit. You can obtain your CE certificate by completing the post-webinar survey. More details on this at the end of today's webinar. As I mentioned earlier, our presenter today is Teri Bedard. Teri will provide real-life examples of billable radiology in EM services. She will also provide important EM coding guidelines to ensure that you select the correct EM category and level of service. Teri, you may begin whenever you are ready.
All right. Well, thank you and welcome, everybody. We're at that time of the year where we've got a lot of changes that we're getting ready to work into and really walk into in 2021. And I want to talk about what we can do with evaluation management, our E&M visits, and how, there's sometimes the question as to, physicians and can they bill for services? And we're really on services that they're doing and separate from the visits that they may have with those patients. So we're going to really walk through kind of where we are right now, how we got here, and then I'm going to talk about where we're going, that precipice that we're getting ready to jump off of, for January 1st, and what that's going to look like. And so you can kind of take away some of that if you haven't heard about some of this information and what you might need to know as we move forward into the next year. So we're going to talk about some of the documentation guidelines. For right now, we're going to talk about, where we're going with 2021 and what are some of the concerns. How do we, we're about a month and a half out from 2021 starting. So how do we even take what we know at this point and move forward? And what are some concerns and things we really need to watch for? So let's look at what are some of the opportunities when it comes to E&M. And when we think about the radiology area, from a diagnostic standpoint, the opportunity is really not going to be there much. There's some slim chances for some things. It just depends on some of the settings. But the bulk of the opportunity for evaluation management really is going to fall within the interventional procedures. And we think about some of those procedures and the interactions that we have with our patients and, determining, what's going on. They presented to the emergency department. They presented to their primary physician. There's something going on with them. And there's a procedure that we may be performing to help treat them, to help manage them. But do we always get to bill for that visit? And is there opportunity, if we haven't been utilizing that, to bill for a visit? So let's think about we're going to kind of walk through a couple of, of understanding when we can and can't bill for things. What are some of the areas and guidelines we really need to be aware of? Because sometimes the work that the radiologist is going to be doing is really a component of or built into the procedure itself. So there may be those opportunities, but there may not. So we really need to understand what are some of those nuances and differences to be aware of. Can a radiologist report an E&M visit? Yes, there is an opportunity. We have to really identify the when, the what, the how of what's going on with that particular patient. And there may be certain services that we can bill. Is it a consult? Not a lot of our commercial payers accept those anymore. Medicare went away with them in 2010. And we really now have our new patient visit, which we have to think about. Our new patient visit is if it's been more than 3 years that a physician or someone within that subspecialty practice has seen that patient or provided a service, they're considered new. If it's within 3 years, they're considered an established patient. So we're going to talk about the differences of that because we're really going to focus a lot more on the outpatient perspective with E&M, because that's where we're really seeing some big transitions from 2020, what we've done for the last couple of decades, really, into 2021. So I want to focus on those kind of areas. What's important to understand from the ACR is it's not something that's new. I mean, this isn't something that all of a sudden popped up on the radar for radiologists to be able to perform and bill for an E&M service. This is something even back to 2008. There's been, information and guidelines about it that services can be identified, documented, coded, and billed. Without a system in place to do this, though, interventional radiologists are providing separately identifiable services at no charge to the patient. So we really need to understand that, like I said before, for diagnostic, it's probably not going to be as common as it would be for some of our interventional radiologists to be able to support, to have and bill that evaluation and management visit. So understanding kind of when you think about your procedures, what are the things that you focus on, and looking at the patient volumes and who are coming in, what are some of the work and resources that are going into those procedures? And understand there may be that opportunity if you're not billing for them yet, or if you are, making sure you understand some of the changes coming up and so that you're billing correctly and getting paid appropriately. Because as we move into 2021, with the changes that are coming up for E&M, one of the things that is happening is that we're seeing some significant cuts across the other specialties because Medicare is budget neutral. So if they're going to bump up the rates that we get paid for evaluation and management, they have to take it from somewhere else. And radiology is looking at it, taking a brunt of that impact. And it's there's a lot of work behind the scenes that is going on to kind of really legislate with Congress and to kind of intervene. But we have to know that even if we don't bill for the E&M services, maybe they're part of what we're doing, there is an impact overall that's going on from some of the changes that are going to be happening into 2021. So I want to just kind of highlight that. But how did we get here? How did we get to this point where we've been talking about E&M and all these changes that are happening, and what does it look like from the standpoint of understanding what it means for me in my practice? Excuse me. So Congress released some 95 guidelines, and we've had those in place since 1995. We are going into 2021, and we've been using these guidelines for the last couple of decades. And we've also had some updated guidelines in 1997 that really favored some of the subspecialties. And these are the two guidelines that we've used to kind of, determine the history of the present illness, how many review systems, the number of physical exams that we perform on the patient. We had to meet all these checkbox criteria. And there's been a lot of requests over time to really update the guidelines. They really need to get in with what processes are that we're using. How are we treating these patients? It's very different than where we were in the mid to late 90s. And even our documentation, the ability and how we use electronic health records is a huge impact to E&M as well. So we want to make sure we understand what that's looking like and the impact that has. So from a historical standpoint, that's part of why we're looking at some significant changes. So currently, still in 2020, and what's important to note is that these guidelines will still exist in 2021 for inpatient visits and some of those other visits that we have that are not considered outpatient or an office-based visit. So there'll still be the history of present illness. We're still going to account for the review of symptoms, what the patient comes in with, what they're telling us about how they're feeling, and And we're also going to look at the past medical, social, and family history have an impact now. We're looking at how many of those we're documenting, and that really gives us the level, it helps us determine the level where we're going with this. The other part that we're still using is the examination. So we have body areas or organ systems, and there's a threshold that we have to meet for each different level. We may have to make sure the documentation's there. What's concerning about these two areas right now with our electronic health records is when you look at your templates. Before we really got into the electronic health record, you would dictate a note, and you might just address, 3 or 4 physical areas that you examined, or a couple of review systems that maybe they filled out in their intake form. And there wasn't always this grand amount of detail or a grand amount of information. Now with electronic health records, what we're seeing is that it's importing a lot of information from multiple different areas within the electronic health record. It could be that you maybe only examined 3 body areas, but it's going to populate documentation for every possible body area in that template. So it looks as if you've got this very comprehensive note, which can be deceiving. And one of the other difficulties with some of this really has been how we've utilized the EHRs and how we've really utilized the copy and paste. And I think that's one of the big things too, because the problems we've seen is that some of the guidelines now are burdensome. You have to get through all these check boxes and get through all these levels to make sure you've got the quantity. And there's more of a push sometimes to get that quantity met than the quality maybe at the visit. It can also be very difficult at times to determine what happened in that encounter. There could be some very outdated or irrelevant information because maybe it was copied forward from another E&M visit by someone else, or the last time that a patient was seen by someone in that group or someone in the system. And so it's difficult to understand. I think that's one of the main complaints that a lot of coders have had over time is what happened in this encounter. It's really difficult sometimes when we have this detailed note, and it could be 5 pages, it could be 2 pages. But determining what actually happened in that encounter versus what's been pulled in from other physicians and other visits, and that's created a lot of issues. And so for that reason, that's why there's been a lot of lobbying. There's been a lot of requests for changes to E&M. So we now find ourselves a couple of decades later from when they started the initial guidelines for 95 and 97. And over the last couple of years, there's been really a flurry of activity between Medicare and the American Medical Association, the AMA. And what happened really is through a lot of requests, a lot of feedback by stakeholders, CMS had actually requested to get some information. How do they simplify E&M? Because the 95, 97 guidelines have really come from Medicare. And then the AMA also has their own guidelines. When you look at the definitions of the codes, they don't always match what we have right now. And so what CMS did, they actually finalized a significant number of changes that went into effect. Well, they finalized them in 2019 to go into effect in 2021. What's important with CMS to understand is they really don't give us much of a heads up. It's pretty rare they give us a 2-year headway that things are going to be happening. In that time that they finalized these changes, the AMA also had their own committee, and they came through and put together significant changes and revisions for outpatient visits to go into effect in 2021 as well. The difficulty is that, as you know, as providers, when you have guidelines that don't match from one payer to the next or from one authoritative guidance to the next, it's difficult because now you've got to think, and who's the payer for this patient? Who's the payer for this patient? How am I documenting? And it can really, from the volume of E&Ms that are done, this can really be a problem. So CMS actually kind of scrapped everything that they had finalized and aligned themselves with the AMA. So when we look at, and I'm going to go over the definitions, the time values, and all that, those are all the same. What CMS is now aligned with AMA. So it's really one set of code definitions and one set of time values as we move forward. And your commercial payers, because these are outlined by the AMA, would follow these same guidelines. So that's kind of a breath of fresh air as we're moving into these next, couple months here, that everyone's kind of aligned and really making sure that everybody's on the same page for this. So as I said, part of the motivation in making these changes and what we do within our radiology practices is understanding that, from the AMA perspective, the documentation for EMS office visits will now be centered around how the physician thinks and how they take care of that patient. It's not just trying to check boxes and trying to get to these level of services that are provided. It's really what's going on in that encounter. And CMS is kind of along those same lines, that the documentation is going to be more streamlined. We are no longer going to have the history and physical exam that will help decide the level that we bill. They'll be pertinent as necessary for that visit with that physician and that patient, but they're no longer going to be key factors into determining what we actually bill for the service itself. So let's step back a little bit. Now we kind of know the history, kind of where we're navigating to, but what is the role for radiologists? How do we understand, we have a lot of codes that we bill, a lot of procedures that we perform. How do we know and understand some of the services that we provide and what we can provide in addition to? So let's define the role of the radiologist. A lot of times the radiologist is sharing their results of imaging and studies that were provided. They're looking at, the patient presents to the ER, or they present to the doctor's office and they come with scans from somewhere else, or they come from, with results from somewhere else. And we're looking at that, or we're conducting our own tests and our own exams and determining and conferring with other physicians on how to treat this patient. So we're evaluating that patient and determining how do we best treat them. But how do we determine, based upon the codes and services, do we get to bill for it? Because there's a lot of work into determining if we can treat a patient, if we can, if we need to do an angiogram, if we need to do an embolization. But what does it mean by understanding, can we bill for some of what's additionally being happened outside of just the embolization itself? So let's determine what a visit is, because sometimes that can be confusing as well. And I think what you're going to hear are some terminology changes. We talk about visits now, but we're going to hear the word and the term encounter used a lot more in 2020 from an outpatient perspective. And you'll kind of see that as we go through why that's going to be a little bit of a shift. So the visit is that face-to-face service. This is when the physician is going to meet face-to-face with a patient. And we're talking about, exams are going on. We're evaluating some of the other services, the tests, pathology, other radiology. What are some of the concerns on conferences that may be going on for that particular patient? And each level of E&M service may be used by all providers. So regardless of what your specialty is, you have the opportunity to bill for this service with the patient and making sure that your documentation really supports that. So the visit is really that face-to-face with the particular patient. We may do a lot of pre-work. There may be some post-work that happens, but in and of itself, the visit is that face-to-face encounter with a particular patient. What's important to note, and I think this is something that comes up every so often, is part of what we do with radiology is we are delivering results. There's an exam, there's a test, there's a scan, something that may be performed for this particular patient to get a bit more information, maybe figure out, what's going on to help diagnose them. But the results in delivering those results is not necessarily a billable event. A lot of times it may be part of that diagnostic study. So, when they come forward and say, well, I'm going to meet with the patient, tomorrow, they just have the scan and we've got the results, or I'm going to call them, or whatever that encounter may look like, or that visit, just because we're delivering the results and it's happening separately from the actual procedure doesn't make it a billable event. So this is where it's really clear to understand that we want to document that interaction, but because we're just simply delivering results of what, of a test or procedure that was performed, doesn't make it actual billable to the particular patient. So what are those times where maybe we can bill for something that's in addition to a procedure? When we think about some of the different procedures that we perform in radiology. Currently, there is no code for the removal of the non-tunneled CVC. So regardless of whether it was peripherally or centrally inserted, there isn't a code that we have to identify that. However, for this type of encounter, for this type of procedure and the work that's done, it's possible that if the documentation meets the E&M criteria, we could bill a low-level evaluation and management visit for that work. Now, the work in removing that, we still have to go through and meet currently, the review systems, talk about, the physical exam, kind of how we're managing that patient. But the opportunity is there to bill for this. So this is one of those nuances or separate things that where we do have the opportunity to bill for something separate from the procedure. I think one of the other big issues, and this is where some of the reimbursement changes for next year, and it's quite possible that the changes that are proposed for next year may look different than what was proposed. We're still waiting for the final rule to be released. The rule will be released, it's supposed to be around the beginning of December. Normally it's the beginning of November, but because of COVID response, they've delayed releasing those rules. So there could be some nuances and changes, but the global package is something that we really do have to consider with the types of procedures that we perform interventionally, because there may be instances where even if we could support that the visit was separate than the procedure we did, we still can't bill for it because the work that goes into managing that patient for whatever the procedure may be is bundled into and part of the reimbursement we get for the procedure itself. So that would be kind of like double dipping. And so there's some things that we really have to consider and understand when it comes to the global package. So there's different sets of global periods that occur with regard to surgeries or what would qualify as surgeries. And this is where it can be including on one day pre-op, the day of, and even up through 90 days after that surgery, we may not be able to bill for any additional evaluation management visits. They're part of everything that we've already performed. So let's think about and understand what does it mean by some of these global periods. If you see a CPT code, and within the RVU file that CMS puts out there, and there's a couple other resources available, you may see the designation for a global period that looks XXX. And that means that it's non-applicable. There is no global period. So if you perform this procedure, it's possible the E&M could be billed on the same day as the procedure. It could be, the next day, the day previous. For some minor surgeries, there may be a 0 day, which means only on the day of the procedure can you not bill for the E&M. It's all of that work is part of the procedure on that day. Another minor procedure has a 10-day. So this is where the day of the procedure and then following, we can't bill for any follow-up or E&M visits because it's all part of, the work is part of that reimbursement. And then when we think of some of the major surgeries, so the day before the major surgery, which may be some pre-work that we do, the day of, and then 90 days after, we cannot bill for an evaluation management visit because that's really part of the evaluation of everything that's going on for that particular patient. So let's look at some of the, some instances and things that you may perform that may be part of what you do from day to day. And maybe you can't bill for some of your E&M visits. It depends upon the timing of things. So some of the minor procedures that are really common for interventional, when we think about carotid arteriograms, some of our breast biopsies, lower extremity revascularization, and dialysis access revascularization. Those are considered minor procedures. So they may have an indicator where we can't bill an E&M on that date of service, or at least on that date and for at least the next 10 days. Beyond that, if there's management visit with the patient, it may be billable for that particular patient if they had what's considered a minor procedure in this instance. So what are some of the other codes and kind of looking at just kind of examples of each of the different levels? The 36200, the placement of the catheter in the aorta, doesn't have a global period. So it is possible, if supported, medically necessary, we could bill for an E&M on the day before, the day of, even the day after, if that was something that was needed for that particular patient. The venous embolization, the 37241, has the 0 day. So everything on that date of service is really part of that procedure. So visiting with the patient, discussing things would not be separately billable. And then the insert tunnel CVC, the 36558, that has that 10-day global period. And then the cervical carotid stent placement, 37215, has our 90-day global. So just remember, you can't, anything you do pre, the day before, the day of, and then for 90 days after would all be part of the reimbursement tied to that. So any visit with a patient may happen. You want to make sure you document that work, but we're not going to be able to bill for it separately in this instance. So let's also talk a little bit about some of the pre-procedure visits. There's a lot of work that happens before some of these procedures. We're visiting with a patient, there's exams and tests and other things that are going on, but in a lot of instances, that pre-procedure visit should only be charged if the patient's condition has maybe changed. There's been some kind of significant change since we last saw them. And this is where medical necessity, the documentation really is going to support that. The note should be very clear that the reason the patient had to be seen today and we're billing for this visit, maybe there was an accident, or maybe they had some other kind of procedure in between the time of when we initially did our workup, maybe we saw them before, and now we have to assess the patient to determine, can we treat them, or can we actually proceed with the procedure? We may have to adjust things, change things, delay things. And so because of that, there is that opportunity, but it's not going to be standard. So if it is common for you to kind of have a check-in with the patients, it's not necessarily going to be a billable event. It really depends upon what's going on a case-by-case basis for those patients. And, Medicare is really pretty clear about medical necessity as well, and making sure the documentation is there. Medical necessity of a service is the overarching criterion for payment in addition to the individual requirements of the CPT code. So we may be able to support the code and have our procedure note that really outlines the embolization and everything that we did, as part of that procedure. But we also have to make sure that the procedures and other things were medically necessary. If there was changes, if we had to, do something that's maybe not as common as part of something, because of the medical necessity, and make sure that's part of your documentation as well. So you want to make sure that that's clear, because the medical record has to tell a story, and it's not just for us. It's not just for the provider. It really is a lot of people that are in that medical record for any number of reasons have to understand what's going on. And as our patients go to different areas, different places, they have new insurance, we have to be able to make sure that story follows them as well. So let's get into an example right now. In 2020, if we were kind of looking at how we would grade things from this particular scenario, how we would select the medical decision making. So this is an otherwise healthy patient. They're seen at a large metropolitan medical center for intracranial aneurysm diagnosed by arteriogram at a community hospital. So the radiologist performs and documents the consultation, including the appropriate history and physical exam. The plan is to perform that additional angiography, followed by possible embolization, depending upon the results of the angiogram. So based upon just this limited information we have here, we know that there's a number of diagnoses and or management is pretty extensive for this particular patient. We have a new problem, additional workup. The data that's been reviewed is also extensive. We're looking at the personal review of the images, the interpretation of those results from the Metropolitan Medical Center, and then the overall risk for this procedure is pretty high. So currently in 2020, if we were to, the level of medical decision-making at this point would support a high level. And the reason I wanted to point out the medical decision-making is we're going to give some examples with the new guidelines, how the same scenario might work out. Currently in time-based, time is something that can move us into the next level, but it's not going to be, this is not our only factor. But when we look at the time as how we have it reported now, it's really just a threshold, and it's a single threshold. So the question has always been, well, what if I spend 55 minutes or 59 minutes with this new patient? I haven't quite got to 60, so I'm still at a level 4. And so there's the splitting hair sometimes when you're talking to people about time-based, but time can really account for when we have more of the consultative kind of visits with our patients, and we're going over and much more coordination and care. And right now with our outpatient, and this will continue with inpatient as well, if 50% of the time spent face-to-face, so again, it's that face-to-face in the actual encounter itself with the patient is counseling and coordination of care, that time can be the factor that pushes us to the next level or be used as our determinant for what level we bill. So we want to make sure that there's indication right now, that of the amount of total face-to-face time, how much of that was spent in counseling and care, and a description of what was discussed in that visit. So for a particular patient, let's say it's a subsequent hospital visit patient, this is kind of what we might look for some of the documentation to look like as we continue in this year and as we move into 2021. They discuss some disease process and treatment options for carotid stenosis. I explain the risk of further TIAs and or stroke if the stenosis is not corrected, yada, yada. 35 minutes of face-to-face and on the floor was spent with the patient and family. Greater than 50% of this time was in discussion. And for this code, we could bill a 99233. And this will be the same factors that we use for other inpatient visits as we move forward into 2021. What will change, we're going to talk about, is the outpatient visits are not going to be based upon the 50% threshold. And we're going to talk a little bit more about the full day of the encounter, not just the encounter itself. So that's going to be kind of important as we move forward. So here's another example from an outpatient perspective in 2020, what this might look like. So that patient is diagnosed with cerebral aneurysm. They're referred for evaluation of a possible embolization. So the patient is visited with, the physician sees the patient, the family. They discuss the radiology, the prognosis, the treatment options. They spend about 60 minutes face-to-face time with the patient and their family. They also spend 45 minutes to discuss and answering questions, and then surgery scheduled for next week. Based on the levels that we have now, this could be a level 5, a 99205, a new patient visit from an outpatient perspective. I'm going to use the same example as we move forward so you can kind of see how we're transitioning things. I know I keep saying that, but so just kind of remember this example as we have it now and what we're going to look at as we move forward. So what do we also need to consider when it comes to some of the E&M visits for some of the services that we do, the interventional services, or even those from patients that are coming from other areas, and some of the other, E&M visit codes that we may bill? You also have to when it comes to time, there's different ways that we apply time as well. When it comes to discharge services and critical care services, these are strictly coded based on time. And so we have to make sure for that type of a service, the documentation is very clear as to the amount of time that we have for that particular visit. When it comes to emergency department services, there is no time element that's included. This is strictly based on the criteria and, meeting and all the, the different components within the levels of the codes. So just know that time is used quite a bit for outpatient and inpatient, but there are certain services where it's very distinct in that that's all that it's used or it's not used at all. And having those understandings of where that may vary from time to, for those particular visits. Okay, so we've talked a little bit about where we come from this point, what's the history of things going on, why are there some changes that we might have. Now I want to really visit and talk about where we're going for 2021. And remember, these changes that we're going to talk about 2021 are just for outpatient and office-based visits. So anything inpatient, any other E&M visits that we might have, there are not significant changes, but the definitions have not changed, the time values, those will still use 95, 97 guidelines if that's what's part of that determination. It's only for outpatient and office visits. There is a possibility that other versions of other types, emergency department and so forth, may change as well over time, but the focus right now was outpatient first, and then kind of get that ball rolling and then see where we go next. So a couple of high-level things to remember for next year. 99201 is being deleted. The AMA has deleted that code and CMS is recognizing it. This will not be available. And the reason for that is when they really changed some of the documentation requirements from a level 1 to a level 2 new patient, they found that they're really the same. And so rather than create a lot of confusion for people, they just did away with the level 1 code. So we just have 99202 to 205. There is going to be a new add-on code for extended prolonged visits, 99417. So our current codes, 99358 and 359 that you might use, are going away for outpatient only. You're going to have this 99417. We're going to talk a little bit more about how we use that code because it's very possible for some of our services, we may get into prolonged discussions with our patients. There's also a new complexity service code, the GPC1X. We don't know the full G code. It's a Medicare code, which means many of our commercial payers may not recognize it. And we're looking for more information when the HCPCS codes come out and the final rule is released. So there's not a whole lot of detail at this point about the context of that code. The history and physical exam will no longer be used to determine the billable level. Now, if they're pertinent to what's going on with that patient, if that history makes a difference and kind of explains what's going on, it should be included in the notes. If there's an area that we need to examine on that patient to really get a better idea of what's going on from them from a status-wise, it should be documented. But they're not going to determine the level for us any longer in the outpatient perspective. And then it's either time-based or medical decision-making. Those are the two options. So you can interchange between patients. One patient, maybe it makes more sense to base it on time. Another one can be medical decision-making. You're not going to intermix them on one patient, but you don't have to be beholden to just one type of visit as we move forward. So let's look at the definitions and kind of what are some of the changes for next year. These are the new patient visit codes. So like I said, user 1 is deleted. Our definitions, when you look at them, the definition itself pertains to the medical decision-making. And then you'll see the time is actually a range now moving forward. So we have office or outpatient, evaluation and management new patient, which requires medically appropriate history and or examination. It's either straightforward, low level, moderate, or high level medical decision-making. And then our ranges will be either 15 to 29 minutes, 30 to 44, 45 to 59, and 60 to 74. When it comes to established patient, very much the same. We still have the 99211. There is no time that will be associated with that particular code. And this code really is just if the physician maybe is managing staff that may be providing a service. It's not going to be a physician-billed service. Same, straightforward, low, moderate, and high-level medical decision-making. And the time account, obviously, but the ranges, we also have ranges for these from 10 to 19, 20 to 29, and so forth. So that's changing a little bit. And these are the same times and everything will be recognized from CMS to AMA. Right now, some of the time values are a little different between the specialties. So a little bit on the new code, the 99417. This would only be billed if you're using time-based. You would not add on any prolonged services codes if you're using medical decision-making as your determinant. And you have to meet a threshold for the level 5 visits and then go beyond that. And then the GPC-1X, like I said, we don't have a lot of context for this yet. I think for some of our procedures that we do interventionally, we may be able to support this visit. And so we're waiting to get a little bit more information as to how this add-on code will be utilized in some of the procedures and things that we do. So that prolonged service code, this is with or without patient contact on the date of the counter. What's important to know about time now as we move forward into 2021, it's the total time on the date of the encounter. So not just the face-to-face time that we have now, but let's say you spend 60 minutes talking to that patient, but 45 minutes beforehand going over some of the tests, reading, maybe they had a scan or something else at another facility, or you're reading the review of somebody else, in your practice or within the system. All of that time that the practitioner spends prepping for, pulling records, talking to other people, they count that time plus the encounter time. And if you meet the threshold, you have to get a minute above the threshold for each of the level 5, and then at least a minimum of 15 minutes. You can start billing this 99417 in quantity beyond the E&M code. And so this is where it's important to understand that there's a possibility for some of those, a lot of time that you spend prepping for those visits and then the time with the patient, we may be able to support some of these prolonged service codes in addition to the E&M code on that same date. It's a little bit different now than from the prolonged services we have available. So again, you're going to have to make that decision looking at your templates, what you have in place already if you haven't, for setting up something maybe for time-based versus medical decision-making, making sure if we have the opportunity to include history or physical exam in there, but it's one of the two options. There is no other option for these outpatient visits that we may be doing in addition to our procedures. So time, as we move forward, can be used to select a level of code in the office or outpatient setting, whether or not that counseling and coordination of care dominate the service. So remember, right now, if we do an outpatient visit in addition to, procedure, at least 50% of that time has to be spent in coordination and care for that patient. As we move forward, that's not the factor anymore. It's the total time of everything we did as the billing practitioner. It's not the work that my ancillary staff did or the clinical staff in gathering or reviewing or pulling anything. It's what I did. If I'm billing for it, and I add all of that up to determine my time on that date of the encounter. So the definition of time is the minimum time. So it's not the typical time. It represents really the total physician on the date of that service. And the use of the date of service time builds into on the movement over the last several years of Medicare to better recognize what's going on. Medicare has really been their focus has been the quality of care versus the quantity of care, which is odd when we're talking about time. It is quantity, but they want to make sure that the interactions that we're having with the patients and the work that we do are recognized, but they're also quality to what's going on with that patient. So the time is spent with the patient discussing things as we need to, and then any of the work that we've had to do leading up to it is also part of that as well. So these definitions will only apply when the code selection is primarily based on time. So like I said, if we do medical decision-making, we're not going to use prolonged services. We're not going to count everything else that happened on that date of service. Medical decision-making would be for the encounter itself and what was documented as part of that. So the time and medical decision-making are very different in those respects. And when we do face-to-face, there is still a requirement, but there is a face-to-face visit. So even though we do all this prep work up to and leading, beforehand, we still have the face-to-face visit. If the provider time is spent supervising the clinical staff that are performing the visit themselves, that's where we would build the 99211. So that's where that code's going to come in still as we move forward with things. So I know I've kind of said this a couple other times, and it's like, okay, how many times do we say this? But I want to make sure that we understand the time part because it's kind of a change in some ways. And one of the other things that has been, I've noticed with some of the information from the AMA, they've spent a lot of time talking about medical decision-making, which we have coming up here. And that's because the complexity of the medical decision-making moving forward is going to be huge for us. So thinking about some of the procedures and what we're doing, what our documentation might look like, what do we, and this is where assessing those notes and the work that we're doing, we have differences in what we might be selecting. So again, total time on that total encounter day. So that's where we're using encounter versus visit. the face-to-face time and some of that non-face-to-face, and then just making sure it's not your ancillary or clinical staff. It really is the billing practitioner who needs to document that. So a qualified healthcare professional, to further kind of think about what that might mean, is this someone who has education, training, licensure, regulation, and facility the privileges to perform these professional services within their scope of practice and their state, the hospital grant privileges. We want to make sure that they are the ones who have the ability, they can bill for some of these services. Your clinical staff are really working on the direction and the supervision of the physician or the qualified healthcare professional. So they may not be able to bill for these services. So when you see some of the designations of what a qualified healthcare professional and a definition, making sure there's the distinction of, some of our techs would be our clinical staff, but some of our PAs or NPs may be our qualified healthcare professionals, and making sure the work that they're doing, how we're accounting for that time if they're billing for services. One of the other things we also have to keep in mind is some of our split shared services. It's possible for some of the things that we do that the physician and other qualified healthcare professional will jointly discuss, the face-to-face and non-face-to-face work for that particular visit. They may be working together to kind of figure out what to do with this patient, how to treat them, how we're going to manage the symptoms or what they presented with. So that time that they personally spend with each other and discuss about this on the date of the encounter, we only get to count the time once. So let's say we spend, let's say I'm a provider and now I'm talking with my PA and we're discussing this particular patient and we've been collecting and information. If we spend a half hour jointly together, it's not going to be the individual, their half hour, my half hour now becomes an hour. It's a half hour together that we're going to be utilizing for our time. So we're not going to count double time for each person involved. It's really the time of the person who's then going to then submit the billing for this particular visit. So when you look at some of your practices, if you're working with other physicians, doing some split shared visits, understanding how we're calculating some of that will be important too. So what are some of the typical activities that may count for time? Preparing to see the patient. So review the tests, exams, pulling up some of the other things that have happened in their medical records. When were they last seen? Looking at labs. Do we have any pathology that we need to consider? What are some of the other diagnostic scans or imaging that they've had done? What is their history? Do we have something that they've either provided to us with the most recent history that's been obtained on them? And if there's an exam that's actually going on that we're doing during the face-to-face part of the visit, maybe we have to order some new procedures and tests because of what we've looked at historically, what's been going on, and what we determined as part of this visit. Talking with other healthcare professionals, the referrals that we may have, talking with the family, the patient themselves, documenting in the medical record. And I want to really stress about the medical record documentation. The AMA was big about making sure that we're not, if you're inefficient in your medical record, that doesn't get to be penalized to the patient or the provider, or to the patient or the payer. Your inefficiency is not something you get to attack that time on. If we're talking to the patient and, we've seen them before, maybe we know them. We're talking about, how the year's gone. What's it been like for them? Have they gone on any vacations? That is not really part of the visit itself. And so making sure we're tracking the time appropriately based upon what exactly we did for that particular patient. So just a quick, comparison here of what we have for time now versus what we'll have for time going forward. You can see we're going into those ranges that we've talked about. Okay, so this is a quick example. And so for 2021, similar, you may see this, it looks a little similar to the one we did before. So again, the patient was diagnosed with cerebral aneurysm. We're here to evaluate them for possible embolization. So they're seen with their family, and they discuss the etiology, the prognosis, the treatment options, and a total of 60 minutes is spent face-to-face, reviewing, and then 45 minutes is actually spent prior to the encounter, reviewing test results and discussing the case with another physician. And the surgery is now scheduled for the following week. So they've actually spent a total time on that date of encounter of 105 minutes. So we could bill potentially a 99205 and then the 99417 in a quantity of 2 because we've met the threshold of 75 minutes. For the level 5, we've met a minimum of 15 minutes. Actually, we've gone now 30 past. So we could bill these codes and the prolonged services code in quantity on the claim. So we're going to go through some of the medical decision making and kind of get an understanding of what that is, and then we'll open up for questions after this. When it comes to medical decision making, we have to establish a diagnosis or diagnoses that are going on with the patient. We have to assess whether what's the status of things going on, and how are we going to manage what's been presented to us. And this is where it's important to understand there's three elements that are going to be your primary focus with medical decision making. One is the number and complexity of the problems that are addressed during the encounter. So the patient may come to you with several diagnoses or different problems that are going on, but if you're only addressing one, you're not going to be able to bill a higher complexity level because there's other problems the patient has that you're not managing or doing anything about them as part of that encounter. We also want to account for the amount and the complexity of data that's reviewed and analyzed. We actually get to count for each lab, for each exam, for each image that we've reviewed as part of the visit to determine how we're going to manage and treat this patient. And then the risk. The risk has always been something that's there as well, but what are the complications from morbidity and mortality, with their problem, the procedures we perform, the treatments. So all three of these elements will have a component in the medical decision making. And really it's based on 2 out of 3 elements that we're going to determine where we have our documentation met. So when it comes to the problems, we will have minimal, low, moderate, high levels of medical decision making. And it really comes down to, and this is similar, this is not a whole lot of a big departure from what we have now, but it's a little bit of some changes. So if there's a self-limited or minor problem, we're going to have a low level of, or minimal or low level of medical decision making. As we get into more chronic, more acute, that pose threats to the patient, we're now getting to the moderate, we're now getting to the high level of medical decision making. So making sure we're identifying the problems that are presented and how we're going to manage those will be key in how we manage and support the documentation for this particular patient. When it comes to the data reviewed, this is also slightly different than what we have now. Again, we're looking at the quantity, so there remain some criteria for this, but within each of the different levels, we have to meet so many of a threshold. And so we're looking at how many tests we've looked at, how many labs. Did we have to talk to an independent historian? The patient doesn't have the best history to give us, so we're going to talk to their spouse or their daughter or whomever else could give us a more broad history of this particular patient. And so making sure that that's identified specifically what data and tests and discussions that we've had about this patient to help support that component when it comes to medical decision making. And then the risk. This has also been part of the medical decision making. They did a little bit better, I think, in defining some of the levels of risk. From minimal versus, we get into moderate and high, we start thinking more some of the acute responses and the procedures we're going to do. Some of those interventional procedures can be very risky for patients, but we have to make sure we document that potential level of risk for the visit that we may be having with that patient in order to support what's going on. So this is similar to the example that we had earlier. So now we've kind of revamped it a little bit for 2021. So an otherwise healthy patient is seen at a large metropolitan medical center for intracranial aneurysm, and they were diagnosed by arteriogram at that community hospital. So the radiologist will perform and document a new patient visit for an acute life-threatening problem, review the arteriograms of the community hospital, and they review the input from the independent historian. The patient could give them some history, but it's really their spouse that's going to give them a lot more to kind of give us a better idea as to what happened, the timeline of events. So the plan is to perform additional angiography, followed by a possible embolization, depending upon the results of that angiogram. And this presents a high risk to this particular patient. So the problem is high. It's an acute illness or injury that poses a threat to their life or bodily function. The data that we looked at 2 of 3 requirements, which meets the threshold for high level. And the risk itself, it's major surgery with potential risk factors for this particular patient. So for this visit, obviously there'll be a little bit more context, a little more information than the example can provide in this space here, but the medical decision making could support a high level when we're looking at, we get into the 99205 for this particular patient. So understanding how that kind of shifts a little bit what our documentation is going to look like. Okay, so when it comes to, looking at where we are, one of the big things I think we need to really think about is the accurate calculation of time as we move forward, and then understanding the different levels when it comes to medical decision making. We need to be able to make sure that we're accurately capturing what happened, face-to-face with the patient, what may have happened outside of the visit with the particular patient, and making sure that our notes support that information, the potential for documentation that we have. So as we think forward and we're moving forward with some of our next steps, I think a couple of things that we really need to focus on in the next couple of months is we want to make sure we understand that prolonged services code when we think about some of the interactions we have with our patients. some of the interventional procedures and the ability to meet with them and bill for that E&M, some of those visits could be lengthy, and the opportunity to bill for that. So making sure we understand how that's an add-on code and how the quantities are billed. We want to watch for the publication of the HCPCS codes, which should be coming out about mid-November. If not at the final rule, we'll find out a little bit more about the complex services, where some of the interventional procedures could really, when we think about what we're doing with our patients and how we're managing some of those, we could have another add-on code. You want to look at some of the additional educational materials and instructions. The AMA has a lot of information on their website. You can even just Google AMA E&M 2021, and there's a lot of information that will pop up that puts it kind of in a brief synopsis, a little bit more detail than we were able to present here today. I think a couple of the big things: review your documentation templates. How are those going to change from what you're doing now to what they need to be in 2021? And knowing, do you have a separate one for time-based versus medical decision-making? I'm going to use the same, and making sure there's an understanding and having that feedback. If there's not understanding about something that's documented, how are we looking at this? Maybe we need to tweak things, change things, and then understanding some of those problems and the types of risks as well. Just because they present with a lot of problems doesn't mean it's a high level visit, because we didn't manage those. And I think one of the big things with time, there's a lot of apps out there. How do we account for the time accurately? Because sometimes for me, I'm working on something, and all of a sudden something else comes in, and now I'm off to this, this thing versus that thing. And how do I track my time? So whether it's different apps that can be used, whether there's a good way to document the start and stop time, so to speak, of the time, so we can add it all together accurately. So there's a couple things you really want to think about if you haven't already, and have those conversations. Okay. I know that was a lot of information to kind of get into, in this period of time, but I want to open up for questions and see if anything's come through, if there's anything that we can answer, or anything that you might have, and we'll kind of start from there. And if we don't get to something today, if you think about it afterwards, you have my information up here on the screen. You can email me. Just let me know you attended this webinar, and I will assist you.
Thank you so much, Teri, for a fantastic presentation. That was very informational. We do have a few questions that have come in, and for our audience who are not familiar with GoToWebinar, you can use your GoToWebinar dashboard to click the questions section, and then you can enter a question in there, and we will ask it. And as Teri mentioned, any questions that we don't get to today, I will make sure they get over to her so that she can answer those. Our first question that has come in is, what prompted the changes in E&M outpatient and office visits?
I think one of the main prompts is, when it went into there was a congressional, or sorry, it was a presidential letter that was signed where we had to move to electronic health records. And when that happened, that really started to shift and change how we document things. And what, I mentioned a little bit earlier is that there was a lot of copying and pasting that happened in electronic health records. It's something that's, part of the process, and it can be difficult to, when you're looking at documentation, figuring out what's part of the encounter. But as we've changed through time, and we think about from 1995 to 97 to, even 2020, that's a couple of decades in between where processes and the way we treat our patients has changed a lot. And like I said, Medicare is really focused on the quality of care versus the quantity. They want to make sure that the visits are happening as they need to with that patient, not just based on the criterion. So there's really been a push and request on multiple levels to update guidelines and to make them more in line with how processes are now, but also from the standpoint of fraud, copy paste, that kind of cloning of information. They really had to revamp some things because it's got a little excessive in some ways, or difficult to determine what's really happening with the visit. So that was a big push for why we have these changes happening.
Thank you. Our next question is, will we only be able to use MDM or time-based, or can we switch back and forth depending on what is best for the patient or for the specific encounter?
Right, you're not beholden to one or the other. With that particular patient visit, it is one or the other. But you could have, your first patient that you see that day, time-based when it came down to documentation, the work, the visit that you were doing, there was a lot of pre-work that happened in addition to that face-to-face visit. Maybe time-based really makes more sense for that particular one. But the next patient, they're coming with a lot of problems. You did a lot of pre-work because you didn't have a lot of information presented to you yet. So maybe the medical decision-making really makes more sense because of what they're presenting with. You can go between, you're not, like I said, to one or the other. Just for each individual, it can only be one. There is no mixing. So if you do medical decision making, there's nothing about time that we discussed that would be part of or counted part of that visit. They're very distinct and separate in that way.
All right, our next question, and I believe this is the last one we have time for today. If time-based visits in 2021 are based on day of encounter, how is the time documented in the medical record?
That's another good question. This is where we're going to have to maybe figure out some ways to do this. I know this was a question that was presented to the AMA CPT symposium last year. And how do we document time or how do we document to support everything? You still do the full notes, but I think this is where one of the things we may need to look at are what are some of the different apps that may be available. I know sometimes like one more app, one more time tracking thing, but I think this is going to be one of those things where time may be utilized more than maybe the AMA and people, because it's an easier way to go around what we're doing and some of the services we provide. So we have to figure out a way that's easy to support, because if there is an audit, if there is a request to support the documentation, we want to make sure that if we have a 15-minute schedule, we schedule 15 or 30 minutes with the patient, but we're billing them for 2 hours, how do we support all the work that was done up front and the pre-stuff and the face-to-face? So we have to find some different ways and making sure that we're counting that time for that particular patient, and we're not trying to, I kind of spent 5 minutes here. But this, we get interrupted a lot. So I think we need to think about what are some things you do currently for some of the different time-based services that you have, or some ways that you can track that, whether in the schedule, you can add a note or something kind of throughout your day. But there's got to be some different ways. And I don't know if there's the best answer yet. I think this is one of those things we're going to find some more information as we get into 2021 and the context of how some of this gets applied. I think we're going to find some more suggestions and recommendations from authoritative guidance and so forth about it.
Thank you so much, Teri, for all of those answers, as well as such a great presentation. It was very informative. A quick reminder to our audience that you can obtain your CE certificate by completing the post-webinar survey. The survey will be emailed to you 1 hour after the completion of today's webinar. You must complete the survey to receive the credit. You will be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. ICE Magazine is proud to bring our new monthly webinar series to the imaging industry. Next month is our final free ICE webinar of 2020 and will feature Kelly Prey with Children's Hospital of Los Angeles. For more information, please visit theicecommunity.com/webinars. Thanks. Have a great day.
Thank you.